It's now my pleasure to discuss the current session, which is going to be on cancer screening. And most of the people in the room, I think, are cancer care practitioners, but this is what we hope will reduce our business over time, particularly as people age and get into their cancer susceptible years. And the first speaker has the most controversial topic in the world, and that is, should we be getting screened for prostate cancer? And as you all know, there have been proponents and most recently individuals who have come to us and said we shouldn't be doing that, and Paul's going to make that all clear to us. Paul is now the Vice Dean for Faculty Affairs at UNC, but continues to be active in the clinic taking care of people with prostate cancer. And he's done a lot of research over the years on public health aspects of cancer care. So, Dr. Godley, take it away.
I'm going to talk about screening and actually make a modest proposal for alternatives to screening, sort of stepping away, hopefully, from this contentious and heated debate. So this is my initial screening slide. I'm not going to talk about digital rectal exam, even though it's ubiquitous and easy. There is no evidence that this is helpful at all in preventing death from prostate cancer. And this is a summary of the recent recommendations by major organizations on prostate cancer screening. These are all released relatively recently. U.S. Preventive Services Task Force in May of this year.
A little bit more
Sorry.
sound here. That thing works.
The U.S. Preventive Services Task Force in May of this year, ASCO in July this year, in March of 2010, the American Cancer Society had their recommendations, and the American Urologic Association in 2009. And this predates the recent randomized controlled trials that have been published, which are the basis of the other recommendations. And there have been UNC faculty involved in all of these. Russ Harris for the USPSTF. I was in the ASCO group, and my colleague Ethan Bosch. I was in the ACS group, and my colleague Ethan Bosch was in the ASCO group. The data that these organizations used was predominantly the randomized controlled trials that have been published recently, except for the earlier AUA review. And the recommendations, although they seem different, are not really that different. Certainly, ASCO and the American Society of Clinical Oncology, ACS, the American Society of Clinical Oncology, have very similar recommendations revolving around a discussion between the physician and the patient on the risks and benefits of screening. My discussions with Russ on the USPSTF recommendations, he says that these are not in conflict, that these recommendations, the USPSTF specifies just whether or not they think prostate cancer screening is effective. They don't argue that physicians should not discuss this with their patients and individualize care based on the patient's situation. So at least 3 of these are somewhat in concert. The AUA takes a much more aggressive approach, directly recommending screening. The people who are excluded tend to be similar people with less of a life expectancy or life-limiting comorbidities for all of the groups, and they dealt pretty similarly with high-risk individuals, saying that additional research is needed or that there's no evidence for a higher overall prevalence, of prostate cancer causes a different benefit from PSA screening. Although the ACS did say that these individuals should be screened sooner, and the American Urological Association. So I want to show the data briefly that underlies these recommendations. So this, published in 2009, is the European Randomized Study of Screening in Prostate Cancer, ERS-PC. 7 countries, European countries, combined their results, their randomized controlled trials, over 160,000 men aged 55 to 69 years. And there was a lot of variation in both what the PSA cutoff was and the screening interval. So this was one of the major studies that was published in 2009. And these were the results. The control group had, and this is a hazard curve. So the control group had substantially more hazard, significantly more hazard than the screening group. And this is the risk of, or the hazard of, prostate cancer death. And this was the other study that was published at the same time, the PLCO screening trial, prostate, lung, colorectal, and ovarian, and just the prostate portion was published. This is a large US-based screening trial, a little bit smaller, 77,000 men, and they were randomized to usual care or to screening. They had a sequence of events that, if they had a positive PSA that involved a digital rectal exam, and under some circumstances they got a transrectal ultrasound. And they were screened for 6 years. And this is the data that emerged from this study. The screening group had a lot more prostate cancers detected than the control group, as expected. But when you looked at mortality, the curves were pretty much superimposable, and actually the screening group had a few more prostate cancer deaths than the control group. So there was no evidence of benefit from this trial. So both these trials had lots of methodologic issues, but the U.S. Preventive Services Task Force estimated that it would take, at most, looking at the data from these trials, screening 1,000 men in order to prevent as much as 1 prostate cancer death, between 0 and 1 prostate cancer death. And their feelings was that this was not a substantial enough evidence of benefit from prostate cancer screening to recommend screening. And at least for the American Cancer Society and ASCO, there did not seem to be a lot of difference in how they interpreted these findings. So I'm going to suggest something different, that we already know how to prevent prostate cancer, that we already have a mechanism that can prevent up to 60,000 prostate cancer cases every year, and we need to take advantage of that. So this is data from the prostate cancer prevention trial, and so this was published in 2003. I was on the Data and Safety Monitoring Committee for the study. So this trial used finasteride. It's a 5-alpha reductase inhibitor. It's approved for use in benign prostatic hyperplasia and in alopecia. In this trial, we had men 55 years and older who looked like they were at low risk for having prostate cancer. 18,000 subjects were randomized. They did get PSA screening, and everyone underwent a biopsy after 7 years, except we stopped the study early. But everybody up to the point where we stopped the study who finished the 7 years underwent a prostate cancer biopsy, a prostate biopsy. It's a little hard to read, but it just shows the randomization. So we planned on 18,000. We actually got close to 19,000 men. Everybody got a biopsy on both arms after 7 years. And these were the results. If you looked overall at the study, there was a 25% reduction in prostate cancers. So this is the finasteride group, and this is the placebo. If you looked at during the study when patients had a prostate biopsy recommended by their physician, there was still a reduction, and at the end of study biopsies, there was also a reduction for those patients who made it to the end of the study. So pretty consistent 25% reduction in prostate cancers. These are the curves over time showing the number of cancers, and this is years of randomization, years after randomization. Curve split fairly early and stayed separate throughout the 7 years. So why aren't we all using 5-alpha reductase inhibitors to prevent prostate cancer? What else is going on that would keep this from being taken up and used as a standard of care? Well, one small barrier is the FDA, who basically said, oh, you can get high-risk, high-grade prostate cancers and be at risk for death from taking these drugs. And both finasteride and more recently dutasteride that was examined in a trial that had very similar results, a smaller population, higher risk patients in the reduced trial that had also about a 23% reduction in prostate cancer death and very similar results, and it was actually the makers of dutasteride, GlaxoSmithKline, that submitted an application to the FDA and got this response, which was an overwhelming no. And in fact, they said, not only are you not approved, but you have to put a statement in these drugs. Finasteride has been out for 20 years. So you have to put a statement in your package insert that says you are not approved for the prevention of prostate cancer, that this increases your risk for high-grade prostate cancer, and they seemed extremely concerned that the 5-alpha reductase inhibitors would interfere with screening, and we know how well screening works. So just a very specific non-recommendation from the FDA. And this is the data that they used. This is from the prostate cancer prevention trial. You had an absolute reduction in the number of prostate cancer cases. So out of 1,000 men, you get 45 men taking finasteride with prostate cancer. 60 men who did not take finasteride would have prostate cancer. So an absolute reduction. However, the number of high-grade cancers, the cancers that put you most at risk for death, 18 in the group that did not take finasteride, and 22. So an absolute increase in the number of high-grade cancers. And there were a couple of theories about what could be going on here. One theory is that finasteride induces high-grade prostate cancers. So new high-grade prostate cancers that would not otherwise be there are being induced by 5-alpha reductase inhibitors. The other theory is that the that the 5-alpha reductase inhibitors are changing the environment enough that you're just detecting more high-grade prostate cancers. So they're shrinking the prostate so that they're shrinking the non-cancer parts of the prostate so that you're more likely to hit cancer if you biopsy it. And they may be inhibiting the growth of the lower grade prostate cancers components so that the high grade component is more prominent. So that is the theory or the theories of what could be going on. This is more data showing the distribution of Gleason scores. So the low grade cancers here predominantly in the placebo arm or from the placebo arm, and then the high grade cancers here predominantly from the finasteride arm. So what did the experts think? So this is a joint ASCO AUA working group, and they came up with a practice guideline for, or we came up with a practice guideline for what to do with 5-alpha reductase inhibitors. And what we said was that this should be discussed with patients. The risks and benefits should essentially be discussed with patients. There was a question of whether or not high-grade cancers were caused by these, but that it was worth the benefit of the reduction in prostate cancer incidence was worth the at least discussing using this drug in patients who were interested in prostate cancer prevention. So what would really be nice is if I had data here on long-term survival, because that's really the key. It's not whether or not you have high-grade prostate cancer or not. It's whether or not you're dying from what you think are high-grade prostate cancers or not. So we actually do have 10-year data from the prostate cancer prevention trial. We are presenting it in a couple of months in at GU ASCO, but what I can tell you now in advance of that is that if you look at the survival curves for the enrollees who received finasteride and the enrollees that were in the placebo group, they are identical. And if you look specifically at the participants who had prostate cancer, the survival curves are superimposable. So there is absolutely no evidence that the people receiving 5-alpha reductase inhibitors, in this case finasteride, had an increased risk of death during the trial, during or 10 years after the trial. Absolutely no evidence. So my conclusions are, well, I have a couple of conclusions. One is that it looks like from survival data from a randomized trial that one of the theories is correct, that you really are changing the environment for evaluation of the aggressiveness of these cancers with 5-alpha reductase inhibitors, and making it more likely that high-grade cancers are going to be diagnosed. And actually, there is a little bit of evidence in the data from the mortality portion of the trial that the low-risk patients are actually at lower risk in the finasteride arm. So maybe this is something that should be used prior to everyone's biopsy to help bring out potential high-grade prostate cancers and potentially to define an even lower risk group that may not require treatment. So I think there's some space for that. I think we should probably de-emphasize screening as much as this has kept me sort of employed. We should de-emphasize screening and really look at some of the things in my third recommendation. Really look at chemoprevention again as a possible primary prostate cancer prevention mechanism. Those are my comments. Thank you very much for your attention.